right? Because we're painting a picture, right? Right? I don't have time to go into my whole explanation there, but we're painting a picture. And how we paint it is KVP and mass, right? If we color it in too much, we just can't see the picture. If we don't color it in enough, we got all kinds of dots and we're missing information, right? So when sizes change, not density changes like that, right? You have to go mass. Isn't that how you do it now? If you start thinking about it, you see an abdomen like this, what did you change? Mass. You see an abdomen like this, what did you change? Mass. You didn't go 70 to 80 kVp and mess with that, you changed mass. So as the size changes, your mass is going to change. But when you touch that patient and they're hard as a rock, what do you change now? Got the idea?
Yeah.
Okay, so decrease in the size of cells because of lack of movement, corresponding decrease in function because the strength may not be there. Casted limbs, right? Hypertrophy refers to the increase in the size of cells, a tissue or organ in response to increase in demand or function. This is kind of the fight or flight thing. Cardiomegaly is one of them. Does that make sense? I mean, we haven't covered that yet, but you get that, right? The heart's having to get bigger to compensate for, uh-oh, I can't move what I need to move, right? So that's what they're talking about. Hyperplasia, an increase in the number of cells in a tissue or organ, granulation tissue of a healing wounds. So you can see what's kind of going on here. One day I'm going to try and find better pictures, but you can see what's going on, right? Are we going to, when you hear this, are you going to increase factors here?
Might have to.
I like the might have to. So why is the might? Why did she say might?
Depending on the age of the patient.
The tissue. Depending on what kind of tissue it is.
How much, right? So how much of what you're including in your image actually has it? So you're not going to just go automatically change technical factors, except for the things that I start telling you you're going to automatically change them for. But for something like this, you may not. You're just going to go up there, you don't know what you're getting into, and you just take the picture. And then it's like, oh, you know, like this presenting. What scale of contrast should that be? Come on now. Going into next year, it's going to be a little different because people aren't going to have me for clinical coordinator. But some of you in here should know this already. What's it supposed to be? Short scale, whoever said that. What is it? It's long, right?
Yeah.
Now, who in here does not understand that? Everyone understands you're looking at basically a long-scaled, short-scaled image. Is that true? Yes? Okay. So if you saw this, and you did this pelvis or low pelvis at, say, with the grid, right? 80 at 23. And it came out like that. And you went, oh, they probably want to see a little bit better. What are you going to have to do?
Decrease KVP.
I'm liking the increase because we have to penetrate, right? We already know that this is an increase of cells. It must be a lot harder, and we're not getting through. So when you think about this, right, what color is your image if you didn't do anything? If you just processed the plate and didn't expose it, what color is it? Okay, you have a 50-50 chance, and that ain't the right 50.
White.
It's white, correct? And why is it white? And how do I know it's white? Because we work in shades of gray. If I start out with black, can I reverse it? Can I? Does it reverse it? Okay, digitals do when it gets crazy stupid out of the way, but can we reverse it? Are you taking blacks away when you expose, or are you adding black?
Adding black.
All right, so it has to start white. Correct?
Mm-hmm.
All right, so if we start white and we end with white, what happened? Not enough got there. So we didn't color it in good enough. Correct? Now you have to decide, did I not use enough mass or not enough KVP? All right, you getting the idea how this works? I hope I'm taking some of that confusion out, because I got a funny feeling most of you don't know what the heck I'm talking about. Right? We're going to get there.
Are you saying we would increase both technical?
Oh, okay. Do we increase both? Come on, there's at least, how many have I come contact with you in this class? 6, 7 of you? Why don't we increase both? We talked about this.
Dose?
Well, it would be overexposed, but I want to know why, because overexposed doesn't work for me, right? You have to tell me specifics, correct?
It's either one or the other.
I drew a little thing, a chart, and I said, there's this thing called the 30%. What's the 30% rule? Oh, what's the 50% rule?
In order to see a difference, you would change a technical factor.
30% is to see. What's 50? 50%. What did Raphael tell you about 50%?
Is that how much you have to increase it for it to increase the dose?
For a repeat. Right? 50% is to repeat, correct? So if you think you have to go double, you got to repeat. 30% is what our eye sees. Radiologists, I guess, can see 20. I don't see 20. I can see 30 though. Okay? So you're going to change by 30. Thus the steps. So how many times have you heard someone say go up 2 steps? Is that new to you? I mean, I talk about it all the time. It's steps, right? Steps are 30%, right? 6.4, 8, 10, 12, right? So you're going to go up in steps based on the size. So that's a 1 step. That's a 2 step. That's a down 1, whatever, right? All right. What's the 15% rule? You are taking notes on this, right? Because you know these are test questions, right?
It's, I think the 15% is if you increase the KVP by 15%, you double.
That's exactly right.
Yeah.
All right, so now let's just make sure we're all on the same page. 15% KVP in theory is 50% change in mass, up or down. 30% is what we see. 50% change in mass is a repeat. Now, do we change KVP and mass at the same time?
No, one or the other.
Why?
I think because you won't be able to see the changes, if you have to choose one or the other.
If you change KVP by 15%, so let's think about this. What's 15% of, say, 70? So, you're going from 70 to 80. That's not much, right? In fact, that's your range for an abdomen, isn't it? 70 to 80 kV, depending on where you work.
Mm-hmm.
That's 15%. What did you just do to your mass?
Oh,
What's the 15% rule?
you doubled it.
You doubled it. Just by changing the KVP, you've already doubled it if you went up, or you halved it when you went down. What happens when you change the mass? Oh, you're going to add more or subtract more. Right? The only time you really want to change both is when you throw a grid in. So you say, I got a good knee technique, I need to add a grid, I got to go up in KVP for the grid because I need to get through that grid, and then I need to add some mass because the grid's taking it away. That's not the same, right, as having everything else the same, no grid or grid, changing KVP, you've already doubled it. Because if you're changing the KVP, you're doing it by 10 or 5, depending on whether it's an extremity or grid. 10 or 5, right? You've already done 15%, right? Because what, you're using 50 kV, something like that for a hand, and you decide to lower it by 5, isn't that 15% already? So you've already have the mass. Do you all understand that? Because your test is going to be like that, right? When do you want to learn how to use your technical factors? The day after you graduate or now?
No.
Now, because that's my goal for you, okay? All right, does everyone understand it? I don't know you all good enough to know your faces yet, so.
I understand it, but I'm kind of confused. What do you mean that when we change KVP, we're also changing mass? 'Cause
15% rule. What is
I know,
a
I
50?
understand a 50% rule, but like, are you talking about when it's AEC and then mass automatically changes?
Oh,
or-
whoa, whoa, what's AEC? AEC is not even part of this equation, right?
Okay, that's
Well, hold on. What is AEC?
automatic.
And what does it do?
Shuts off.
Shuts off when it's happy, right? For whatever it was programmed for. And what's its weakness?
Perfect positioning over a photocell.
Uh-huh.
Perfect positioning over a photocell.
Yes, it's you. You are its weakness. If you
Love that.
go in a shoulder and you do not put the humeral head over to AEC, you're done, right? It's going to shut off too soon. You don't have a good exposure, blah, 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 blah. Okay? So 15% rule has nothing to do with the AEC. You have everything to do with the AEC. You need to select it, you need to know which ones are on, and you need to get the part over it. Is this bringing back memories for some of you?
Yeah.
Yeah? Okay, big deal. Okay, so hold on. So KVP, when you're changing KVP, you are just trying to decide how you want to paint the picture. How hard do I need to hit it for the stuff to come out the other side so that my picture is painted the way that I want, right? So if I lower it 15%, I am taking the mass down with it. Has nothing to do with the MA or time that you did. Just by lowering the KVP, you've cut your mass in half, right? So if you're going to do this as we get through this, when you start doing this, you're not going to want to change the mass too, because now you're lowering the mass even more, and now you're going to have this polka dotty modeled image that is missing all kinds of information. So that's a 15% rule. It was not just a theory that Raphael and whoever else gave it to you just to stick on the shelf like you learned when you learned, you know, some other thing in school somewhere. This is something you're going to use every day without actually thinking about it. You're not going to go 15% rule. No. You're going to go, ooh, she can barely walk in the room and looks very fragile. I'm going to lower my KVP. Well, you just did the 15% rule without going and bringing out the calculator and, you know, all that. Does that make sense? All right. Does that answer your question? So 15% rule, you're just changing mass one way or another. Double. Okay? So it would be no different than going from 8 to 16. Right? So if you did a chest, say 110, 120 at 8, and did the same person at 16, you didn't hit it harder. You just colored it in too much. And now it's going to be really hard to see anything in that chest, right? Unless the computer fixes it. But okay, and Dennis?
I just want to clarify. So if you increase the KVP by 15%, you're essentially doubling the mass.
Yes.
Okay. Thank
Or
you.
vice versa,
Thank you.
right? Okay, right? So if you increase KVP, you double the mass up. If you decrease KVP, you halved it down. Right?
Would you be able to adjust the mass in an instance where you need to not penetrate so much, but then you know you're cutting the mass in half, so you would bump up the mass a bit?
Right, so this is where you'll start seeing me marking lines on your test, because that's what I want to hear. What is penetration?
The ability to get through.
And that
the
is
image receptor?
that mass or is that KVP?
KVP.
All right, so when you're talking about KVP, you're only talking about the penetration, right? And what is mass?
The quantity of.
Quantity, how much we're putting down,
The number of photons.
the number. So if we have a penetration problem, we are not talking about quality, or I mean quantity. right? Does that make sense? So you have to decide whether or not changing the penetration because something's harder is going to double your mass and give you enough to make your image, right? Because you have to remember, when you go up for something, you're also laying down more, right? But if you don't go up, it won't come out the other side, right? So your hope is that when you go up, the mass that you thought for that size patient, because usually these kind of things are, patients this thick no matter what, but they're just hard as a rock. So you're not changing your mass for the thickness, you're changing your KVP to get through it and come out the other side. Does that make sense? All right, hypertrophy and hyperplasia. So hypertrophy is an increase in size or function of the cell. This is a comparison for you, right? Because we've already kind of went through this. So it's increase in size, response to increased demand or function, bodybuilders, pregnant uritis, increase in intraluminal pressure in a hollow organ, occurs most often in cells that cannot multiply, myocardial and peripheral muscle. Where you have this hyperplasia, it's increase in the number of cells, increase in size, adaptive response in cells capable of replication, hormonal, breasts at puberty, some kind of irritation or infections. All right? So hypertrophy would be like a loss of one kidney and the other kidney comes in, right? So when you get into CT or something like that with contrast, you kind of want to know if they have one kidney or not, right? Might change things, right? But one can get bigger to compensate for the other, right? All right. So these terms are going to come back when we actually get to that part, when we get to the abdomen and you see the kidney, one kidney big, one kidney small, right? Pleasure increase in the celery of bone marrow, right? After a hemorrhage, right? Because it's, all right. So this is, I put this together so you can compare the two because these are wonderful test questions. What is the difference between kind of thing? Dysplasia, a loss of uniformity of cells in the tissue associated with the chronic inflammation and prolonged exposure to irritants. Can be considered pre-malignant in some cases. This can lead to cancer. Neoplasms, the new cell growth and abnormal proliferation of cells. Cells are considered parasitic, competing with normal cells for metabolic needs. This is like tumors, right? So basically what you've already learned from Raphael is these grow really, really fast, but they also die really, really fast. And so when people are going through chemo or something like that, it's a race, right? It's a race. What dies first? Because they're trying to get all these cells to die before your cells.
The normal cells?
The normal cell. The abnormal cells die first, right? That's the idea. Because they grow really quick, but they also get killed really quick, right? This is all Raphael taught you already, right? I don't remember what class that was. It's funny what's going to stick with you over the years, right? So I already know. I mean, he's talked to you about this at some point. I just don't remember the class numbers anymore, right? But so it grows really fast, and they're trying to kill it off. And it goes off really fast with the radiation, right? But all the good cells are dying too. So it's a race to try and get those out while these other ones remain. That's the goal, right? So you have benign and malignant. Benign cells closely resembling the cells of origin and structure and function, highly differentiated cells. Usually can be surgically removed, like it's an adenoma, right? So epithelial layer from granular structures, lipoma, soft rubbery or adipose tissue, and myoma in the muscle. So basically the way I keep it in my head is these are usually encapsulated, and when we get to some of the CT images, you will see that they're nice and round and easy, and then when they go in there, they take that out as one unit and don't leave cells that they can't see behind, right? But malignant. They invade and destroy surrounding structures. They can metastasize, right? So they spread. They do not resemble the cells of origin at all. Carcinoma, it's a malignant tumor at the epithelial origin, and sarcoma, tumor rising from a connective tissue. So you'll see these, and they look all not uniform, weird, right? And then they they can go, right? One of the things that you'll notice when you get into doing other things is that one of the things that's always on the surgeon's mind is how their approach is, because they don't want to put something in, like a needle per se, pull it back out. Because now they pulled all those cells out across every other tissue that they just went through, right? And then that would be like seeding, right? So they're leaving all this behind, and it starts to grow and very complicated. Enchondroma, lobulated increase in bone density, intramedullary neoplasm of hyaline cartilage. This is mostly going to be covered in chapter 4. But based on the conversation we had, if you saw this on your RAC Enchondroma, are you just changing technical factors?
Yes.
I got one yes. Are we changing?
I would say yes. KVP, yes.
Yes.
It's got increased bone density,
Yeah.
right? That's true. But we did a pelvis. And what's the percentage of bad juju to the image?
Just one small area.
It's one small area. So now what happens if you change the technical factors? You affected the entire area. So it would be no. Right? If it's taking up the whole thing, then yes. If it's just a little thingy, then no. Because they're just going to see that dense area on your image, because it's going to be, oh yeah, white. Right? So it didn't penetrate. They see it as that. It's done. All right? So no. The answer for this one would be no. I'm not changing the technical factors because it takes too much of a small place, right? So when you write out your question, you're not going to just say no. You're going to say something in your own words about, it's so small. I don't want to affect the rest of my image. Because when you change your technical factors, you're changing the whole image, right? Okay. Now you wouldn't do this, but if you cone down to that little spot, okay, right? Because that's all you're going to see. All right, so these are considered benign. These lesions replace normal bone with mineralized and unmineralized hyaline cartilage. It can be seen on long and short bones. The cause of cancer, well, you know, we don't know everything, right? There's some things that are starting to come out, get labeled, this is going to cause you cancer. Pumping gas. Can be chemical, right? These can cause DNA alterations as well, genetic predisposition, which they're starting to look at now, UV radiation, gets the melanoma, right, skin cancer, atomic radiation, right, leukemia from these people, DNA, RNA viruses, invade the normal cells and alter it. Clinical signs and symptoms of cancer. So intestinal malignancy, so it could have bloody stool, change in the bowel habits, diarrhea, constipation, obstruction. In the esophagus, we have dysphagia, anorexia with weight loss, the renal area, right? Hematuria, difficulty urinating. Hemoptysis in the blood and for respiratory and persistent cough. So I kind of started talking about this already. So the ways that it can spread is seeding, right? I just think of it like seeding, right? Lymphatic spread, which you all have already heard about, right? Especially the biggest one, breast cancer, gets in the lymph nodes and then it's everywhere, right? And Hematogenous spread, so through the blood, it gets in the blood and it goes all over. So one of the ones that I think came out of your book is tumor penetrating intestinal wall and metastasize to other organs within the peritoneal cavity. Lymphatic spread depends on the route. Major metastatic route of carcinoma. Breast cancer is the one always come to my mind first. Tumor invades a blood vessel. Tumor released into the bloodstream as a neoplastic emboli. Emboli catches the narrow vessels of a distant organ. Neoplasm penetrates vessel walls and then invades the surrounding tissues. Grading and staging. So they do this by the biologic behavior, a degree of aggressive, and probable response to treatment. Staging refers to extensiveness of a tumor at the primary site, presence or absence of metastasis, stage 1 through 4, 1 being small and 4 being probably not good. And this is how they're going to determine the type of therapy, how aggressive they're going to be. All right, I did tell you signs and symptoms are always separate. Whenever I ask you to talk about signs, your paper, presentation, test, signs and symptoms are separate. So these are basically ones that you can measure, right? You can see it and measure it. That's the bottom line. Okay? So these are perceived, right? You're not going to see them. So it's usually a complaint, a headache, feel tired, something like that, right? Everyone get that? Clear? What's an example of a sign? We did this yesterday or Tuesday.
High blood pressure.
Blood pressure measurements, you can measure it. Temperature,
Fever.
right? Because you can measure that. Okay. Symptom is stomach ache would be good. Is a cough?
Both.
Tired.
What's a cough?
Both.
You can see it. It could be, right? Because if I cough on you, there's no doubt I cough, right? But if I say I have a cough and I'm not coughing,
That's a complaint.
then it becomes a complaint. Okay, careful about that. Syndrome, set of signs and or symptoms that are occurring together and are indicative of a certain abnormality. Gulf War, I gotta keep saying every year I'm gonna change that, but because it's beyond you guys, right? Most of you anyway. Down syndrome, right? Down syndrome is still pretty relevant.
Steve, what is World War syndrome? I don't know.
Gulf War?
Yeah.
So, I know, I gotta get this out of here. So, how many remember the Gulf War? Does anyone even here know about the Gulf War? Yeah, so they decided to go over and protect their oil. And things went really bad, and then those guys came back because of all the bad stuff that happened with all this stuff. Today, what would be probably more relevant is PTSD,
Yeah,
right?
that's what I was thinking.
Right? That's probably more in today's world. We send off all these fine men and women, and they get blown up in a Humvee. Those of you at the VA, who's at the VA? Yeah, and you've seen these people, right? I mean, I'm still getting chills because I work there too, right? And you see what wounded really means, right? Wounded is not what you thought before you went to the VA. It's after you went to the VA, you got a whole nother perspective, right? So be something more like that. I think I just need to get Gulf War out because that's way dated. And every year I say I'm going to take it out and I forget. So, but yeah, it'd be something like that. PTSD, right? Right, because they're seeing things that's going on. Oh, the other one is, what are they calling that for the football players? The head smashing. And then they get all violent and all these things happen, and then when they dissect their brain and go, whoa.
Concussions.
Yeah. If you the Will Smith's movie? Yeah, man, that is good. Yeah. I can't remember right off the top of my head right now what they called that, but that's going on with the football players. So same thing, right? Right? Are we good with that? Okay. Classification of disease. So vascular insufficiency, right? So that's affecting blood flow. Immunologic disease, pretty self-explanatory. Metabolic disease, right? Food and energy and organ use, right? Neoplastic disease, abnormal growth. Idiopathic disease, We don't know. Heterogenic disease is the doctor. We talked about that, right? Yeah, sorry.
I love it.
That's
Works.
my signal mind. Infectious disease, so nosocomial infections, community-acquired infections, right? Then there's heredity, passed from one generation to the generation in DNA, right? Okay, so in your book, there's this big list of additive and destructive. You are going to need to know that list. However,